Alrighty, it's a great pleasure to be here in Tel Aviv again with my friends, old friends, and we don't want to say how many years back because then we feel very old, every one of us. So we're going to talk about mitral regurgitation, revisited how we quantify and assess the MR, and there are guidelines that I was privileged to be part of from the American Society of Echo that everybody in the world is applying. And the guidelines here has three groups of signs, specific signs of severity, supportive signs, and quantitative parameters. So if you use that, you're in business. And so we'll see how that works. The thing that we're really good at is when there is no MR. That when there is none, we're absolutely outstanding. When there is some, where it's a little bit more difficult, huh? I have summarized the guidelines here, but it is true that if there is MR and there is just a little bit of MR, then the small jet is in general accurate. Just a little bit of MR, we're capable of recognizing that. If there is more, now it gets to be a little bit more difficult, and in particular, there is no positive signs of moderate MR. So we can say, oh, I recognize visually that it is moderate. We say moderate, and in the guidelines is, if it's not severe, if it's not mild, then it has to be moderate. Not very good, huh? Not very good. So the guidelines have, as a first entry to say severe MR, severe anatomical lesion. And the severe anatomical lesions are lesions like this, where you have the Pepper muscle that you see floating in the left atrium. Same thing here. It's the same patient by transthoracic, where you see the valve completely flayed during an MI. And this kind of lesion is very clear that this is massive MR. I don't need much more. So the lesion itself works. Here it's less impressive, but you still see a flayed leaflet. And there is a little ruptured cord that we see. What does that mean? You can see it by transthoracic. You can see it by transesophageal echo, a flayed leaflet. You can see it by 3D echo, which is very beautiful. And you see here a ruptured cord of the posterior leaflet here, isolated. And you see a ruptured cord of the posterior leaflet here in a patient who was previously operated. So by 3D, what you see is the extent of the lesion, the ring here present, and it's absolutely outstanding with that ruptured cord. And it's easily recognizable. When you say flail, and why this has been included in the guidelines, is because when you say flail, there is 85% chance that this is severe MR, which is good in practice because we don't have that many signs that are that precise. But you still have 15% that are less than severe. And so you need to be able to say, okay, there is a flail, but I recognize that it is less than severe. So it's an important point that you need something else, but it's useful. When you see a flayed leaflet, you start with the idea that until proven otherwise, this is severe MR, and you process that way. So you can use, as a method, vena contracta, and vena contracta is what you see here. So the tricks of vena contracta is you need to see the three components of flow: flow convergence, vena contracta, and the jet. If you don't have the three components, don't use it. And then the flow convergence here is recognized because there is a little blue part of the flow going down toward the orifice, a little red part of the flow going up to the orifice, and then you have the marker of the orifice here, which is the vena contracta, and you can measure that. Now, the trick is that you have to be perpendicular to the jet so that you use the depth resolution of echo, which is much better than the lateral resolution of echo. And if you do that, if you can have a jet like this, it's measurable. And if it's more than 0.65, then it's severe mitral regurgitation. It's okay, you can use that. Rarely, the quality of the vena contracta is sufficient enough to do this. You can use pulmonary venous flow, and pulmonary venous flow is a very good thing. If you have systolic reversal, it's mentioned as a good sign of severe mitral regurgitation. Now, this is an old slide, but I had these two patients in my echo morning at the same day. Both of them, we quantified the MR, and they had 65 cc's of regurgitant volume. One, this guy, has a large reversal of flow in systole in the pulmonary vein. One has none. And the explanation for that is that the flow reversal is not related to the amount of regurgitation, but is related to the presence of a V wave in the left atrium. So a non-compliant left atrium, you have a V wave. And there are two reasons to have a V wave that we'll call a reversal. Either the whole left atrium has a V wave because the pressure is elevated, or the jet hits close, the wall close to the venous orifice, and it creates a local V wave that produces the reversal. This is why you can have an asymmetric reversal when you do TE, that not all the veins are with a reversal. So venous reversal, what do we have to remember? It's a specific sign. It means that you have high positive predictive value. When you see it, it's very predictive of severe MR, but it has a limited sensitivity. So you do not see everybody. You cannot count to detect all severe MR by venous reversal. So what most people use is color flow imaging. And with color flow imaging, you see that's a nice combination of jets, and you see these jets, two going to the external wall, two going to the septum, and you say, okay, among those patients, who has severe MR? Who is the most severe? Who is the least severe? It's very difficult to say, you know. I've been in this business of doing echoes for a long time, and I have a hard time saying this is severe. I can give you tricks, but it's very difficult. So in our practice, we need something that is communicable. And in addition to that, you know, we did a study where we measured progression of MR, and by quantitative measurement, we saw that there was an increase of mitral regurgitation, but the jet did not move, was the same. So it's very difficult when you see a patient year after year to say, oh, your mitral regurgitation has increased, because you cannot detect it by the jet, and it's very difficult to detect progression of MR. So in the guidelines, we said if regurgitation is more than mild and you know what you're doing, you should assess the MR quantitatively. And to do that, you can use Doppler, and Doppler measures stroke volume on the mitral and the aortic orifice. The mitral stroke volume is bigger. The mitral stroke volume is bigger than the aortic, and the difference between the two is the regurgitant volume. So in theory, very easy. And here is an example of aortic stroke volume 71, mitral stroke volume 218, and the difference 147 is the regurgitant volume. Very big time MR, massive amount of mitral regurgitation. Now, it's not easy. This part everybody knows because we use that for aortic valve stenosis. This part is a little bit more complicated, and you need to educate yourself. Once you've measured the regurgitant volume, you can calculate the effective regurgitant orifice as the ratio of volume divided by TVI. And here in this case, 147 divided by 216 is 0.68 centimeters square. And we'll see what this means in a moment. But you see, the problem is that when people trace Doppler, they trace in general outside, and that's for gradients. But if you measure flow, you want to trace on the whitest line, which is the modal velocity. And you need to trace on the modal velocity. And what you need really to do is to address the overestimation of the mitral stroke volume by working first on normal patients who have no regurgitation, and you should find the same amount of stroke volume on the mitral and the aortic. So if you want to use that method, you have to have a little time. If you're in a big hurry, don't do it. And the second, you need to train yourself by doing the normal subject. Or you can verify by measuring left ventricular volume. That ventricular volume sounds easy. It's kind of difficult. But there are new methods that are very interesting of detecting the ventricular border by speckle tracking. And I promise you that soon we will have automated methods to measure ventricular volumes in a reproducible way in the humans. And so that will make that method usable. But what we use mostly is the PISA method, which stands for proximal isovelocity surface area. And what we do with that method is we zoom on the jet area, on the origin of the jet. We move the baseline down, and now the zone of flow convergence appears in yellow, and you see the flow convergence, the neck of the jet, of the vena contracta, and then the jet. And so when you have that, you stop a frame on the T wave, so you're in mid-systole, and you do not turn off the color, and you see the neck of the vena contracta here that appears in black, and you have the three components, the flow convergence, the vena contracta, and the jet, and you measure the radius of the flow convergence, and you can calculate by this formula here, I'm not going to repeat that, the flow at that moment in time, and you can calculate the effective regurgitant orifice as a ratio of the flow divided by velocity. It's always the same formula. Huh? You have to remember that blood is incompressible. The big physiopathologic secret of that is blood is incompressible. It's not like air that you can compress. So flow is constant, and it's always flow is equal to size of the orifice multiplied by velocity. So you transform effective regurgitant orifice as flow divided by velocity. So flow, velocity by Doppler, the ratio of the two is the effective regurgitant orifice, 0.53 centimeters square in this case. And again, we'll see what that means. And so the great virtue of the American Society of Echo guidelines was that the words that we use, the mild, moderate, severe, the old angiographic grading, and the numbers that we have are in the same range. So if you say severe, it is grade 4, and it is more than 60 of regurgitant volume, more than 0.4 centimeters square or 40 millimeters square. So if you want to do those measurements, you have at least a coherent gradation system. And like everything that we do, quality control is everything. You can give a stethoscope to a monkey, and it's not the stethoscope that makes the auscultation, it's what you have in between the ears. And so that's the whole thing. Quality control is medicine. If you don't have quality control, better be in another business. You can clean the floors, you can do anything, but quality control in medicine is everything. So, for example, in our case, if you have a flow convergence that is compressed by the calcification of the annulus and does not apply the formula, the hemispheric shape, don't measure it. You have to be able to judge what you're doing. And so, and sometimes the flow convergence is not always spherical. It can be a little flatter close to the orifice, a little bit elongated at the distance from the orifice. And here's an example of that, where we had exactly the same image, and I modified the velocity, the Aliasing velocity. This is very long. That's a pastèque, huh? It's a watermelon. And the watermelon is not measurable. Don't measure. You increase the Aliasing velocity. It's a little closer, and then you move it up one more, and then you have a nice flow convergence that you can measure. So you have to be able to judge what you're measuring and to make a judgment on that. And the shape of the flow convergence should look like a ball sitting on the jet. The principle is that it is hemispheric, but because we do not see the lateral flows, it looks like a ball sitting on the jet. If you have this shape, it's a good shape you can measure. And then you can measure the peak velocity, but if you cannot measure the peak velocity, there is a simplification that you can use. So you need to be able to understand complicated situation. And so, for example, here, you have several jets, and they cover almost the entire left atrium. The tendency would be to say this is severe mitral regurgitation. But then you do the PISA. You can measure here 2 of the 3 jets. In fact, there are 3 flow convergence. We measure the 2, and we make a calculation where we integrate the 2 radius to have a total radius, and we calculate, and the regurgitant volume is only 40 cc's. So we have saved an operation to this patient who was referred for surgery because we're able to quantify the MR and show that it was not severe. And so the tricks that we have to apply is to define the flow convergence, then zoom on the image, zoom greatly, and then move the baseline. You have to judge that there is a good shape. Do not accept bad shape. Do not turn off the color. The color tells you where the orifice is, and use the standalone continuous wave Doppler to get the MR velocity because it is more sensitive than the guided Doppler. If you apply those tricks, our sonographers are doing it every day. They're doing it very well. So if sonographers can learn it, I suppose that doctors can learn it too, although it's more difficult with doctors. So interpretation of measurement is like everything. Again, a creatinine is a number, but you make an interpretation of the creatinine. The same number doesn't have the same value in a tiny old lady and a giant muscular guy. So you make an interpretation of numbers, and the interpretation is based on looking at the outcome. So this is the paper we had on quantitative determinant of outcome, and you can see that in organic MR, if you have a regurgitant orifice of more than 40 millimeters square, there is an immediate risk that is with excess mortality. If you have a regurgitant orifice of 1 to 19, you live forever. If you have an intermediate regurgitant orifice, the first few years are okay, and then the MR progresses and you have excess mortality later. So that's organic mitral regurgitation. And this data that we published were confirmed in a study from Korea, where the effective regurgitant orifice was predictive of outcome, and was confirmed in a study from Argentina, which showed that the effective regurgitant orifice was predictive of outcome. So there are now 3 studies showing that are large, showing that the effective regurgitant orifice is predictive of outcome. So there is no discussion. It's not, oh, will I do it or not? You do it. You have to do it because it is predictive of outcome. There is no discussion about it. And so we need to do it. Everybody needs to do it. Sometimes the continuous wave Doppler is a little weird. The first part of systole is absent, and you have that part. Should we use the effective regurgitant orifice in this patient, and how should we use it? And Jan Topilsky, who was working with us, is Israeli by heart and lives here in Tel Aviv, has done that study and was just published in Circulation, where we looked at people who are matched holosystolic MR and mid-late systolic MR. And what we saw is that the people who have mid-late systolic MR, which is here in yellow, irrespective of the size of the orifice, have smaller regurgitant volume, smaller left atrium, smaller left ventricle, and smaller and lower right ventricular pressure. So all the consequences of mitral regurgitation were smaller despite the fact that they had the same regurgitant orifice. And most importantly, for the same regurgitant orifice, the mid-late systolic MR had a better outcome. They did better. So when you have end-systolic or mid-late systolic MR, the regurgitant volume is a better measure of the severity of the MR than, whereas in holosystolic MR, the effective regurgitant orifice is a better measure. So that's a very important point in saying be careful in what you're doing. And it's particularly important because the size of the jet looks as big in the holosystolic and the mid-late systolic MR. The jet will not allow you to understand what's going on. The regurgitant orifice is the same. The flow convergence is the same. Pay attention to that. Okay? And you have to know which disease you're dealing with. This is flail, this is functional mitral regurgitation. So if you have functional mitral regurgitation, and we looked at patients with enlarged left ventricle, you compare functional and organic with the same enlarged ventricle, the functional MR have only 26 cc's of regurgitant volume, what we would call mild, whereas the regurgitant volume in organic MR is 100 cc's. So is that anything significant, that functional MR? Or is it just something that we can neglect? And when we looked at that, we said, okay, what is the gradation for functional MR? Should it be the same as organic MR? But when you look at outcome, it gives you an information on what's happening. And you see that here are the people without MR, the same EF in every single group. They have, at 5 years, an acceptable survival, 60%. The people who have the most MR have that survival divided in two. But what we call the most severe MR is not 40 millimeters square, it's 20 millimeters square. So the scale is not the same in functional MR. And so when you look at what is severe MR, in functional MR, it's a 20 millimeters square that tells you this is severe functional MR. So what we have to do is the same thing that we do in medicine with everything. We get the numbers and we interpret the numbers in the context of the specific patient. And if we do this, we're safe. So do we serve the patient? Let me give you some examples. Here is an 82-year-old woman, recent atrial fibrillation, and she's referred for atrial fibrillation ablation to our colleagues, to our electricians. And so you see the standard echo, barely anything visible, and you look at that and you say, okay, well, there is a mitral valve. And you look at the color, you say, maybe a little more than what I expected. And then you do the quantitation, and you have a large mitral inflow, and you are able to look at the PISA, and you quantify, and you see that she has a pretty big regurgitant volume, 92 cc's for that poor lady. And in fact, we go back and we look and we say, oh, we can produce some images, and the images shows that this lady has a flail anterior leaflet. And you see the ruptured cord. When we look in the corner and we press our way, we see that she has a flail anterior leaflet. So what she needed was not an ablation of the atrial fibrillation, but the mitral valve repair that she got, and she went back into sinus rhythm after the operation. So we have to be very careful with that. Another case is a young man, 37-year-old. He has MR. He's told by his cardiologist, oh, this is mitral valve prolapse. You're safe. Everything is fine. His wife hears the murmur when she has her head on his shoulder, and she says, you know, I don't like it. You better go and have a second opinion. And so the guy comes to us, and he has a 3/6 murmur, and he has a pretty big prolapse, but still a prolapse, no flail. We do the color. We see that there is a blast of color, but mostly systolic, and you wonder what it is. And so in this patient, we look at the ventricle, and that's a big ventricle, so that's a little troubling. And we do a double quantitation by PISA here and by Doppler, and both come to the same thing. He has a massive amount of mitral regurgitation, more than 100 cc's per beat. This guy needs a repair. But you see, and he has a perfect repair. Perfect. Not a drop of MR left, but what is left with him is that he has now a very bad ventricle because he waited too much, and he has LV dysfunction, and he should have been operated 3 years when he was reassured that everything was fine, was a mitral valve prolapse, was benign. That's when he should have been operated. But fortunately, we could treat him, and he could recuperate somewhat. So what we have learned today is that what we need to have is, for MR assessment, is high-quality echo. Everything starts with high-quality echo. Comprehensive evaluation is mandatory. Quantitation is superior to qualitative assessment to assess the severity, the progression, and the outcome. And quantitation is the key for us to early referral to surgery to preserve life outcome. And like everything, we interpret the quantitation, the effective regurgitant orifice, and the regurgitant volume in context. Thank you so much for your attention.
The next speaker is Ariel Cohen from Paris, and he will speak. His title is The Role of Preoperative Stress Echocardiography Before Mitral Valve Surgery.